Good morning, everyone. Can you hear me there?
Yes, sir.
Okay, thank you so much. I would like to actually thank everyone, the leadership team and the committee leaders for this conference at Nandha Medical College for extending me this invitation. And they say life comes at a full circle because Dr. Rajesh was actually my HOD at dermatology when I was an intern and medical student at Perundre Medical College. So it's my honor and pleasure, and Dr. Chandrabose sir, who was my physiology HOD as well, and my dear buddy, Dr. Arunprasath. So shout out to all the folks that I know, and I really thank the leadership for giving me this opportunity to share my honor and passion of actually studying the relationship between cardiometabolic diseases and inflammatory disease states like psoriasis. And Dr. Rajesh sir couldn't have given a better like a runway to my talk. He actually put it. I don't know if you saw my slides already, but he actually put it right exactly what I'm going to discuss. But I'm actually an interventional cardiologist by training, and so meaning like I like to do procedures and fix but stents and also do valvular heart disease procedures. However, my passion is also in cardiac prevention, and I spent a few years at the NIH and University of Pennsylvania studying with my mentors, Dr. Dan Rader and Dr. Neil Mehta, who I kind of like endo everything that I've done so far, where I studied this fascinating relationship, and I continue to work on it along with my clinical responsibilities. With that, I'm going to get started. So the task I've been assigned to actually talk in the next few minutes is about studying the relationship between cardiovascular or cardiometabolic diseases and chronic inflammatory disease states. Very specifically to the particular to the today's talk, it's about cutaneous cardiac nexus in psoriasis. I have nothing to disclose, no conflict of interest. Are you able to see my slides? Okay, so as you can see, the cartoon here depicts the natural pathophysiology of progression of atherosclerosis and development of coronary artery disease. It is actually a cross-section of a coronary artery with all the three layers there, tunica, intima, media, and adventitia. And you can see that the process starts with endothelial dysfunction, and it actually results in lipid accumulation. The lipid accumulation part, so far that we have known, happens because of traditional risk factors, but there is more to it, and that's what this talk is about. But there, when the lipid accumulates, it triggers a chain of reaction and it accumulates inflammatory cells, which in turn results in smooth muscle cell proliferation. And because of these mechanisms, you actually have a non-calcified soft plaque. A plaque is made up of mostly lipid-rich particles if it's a non-calcified, or sometimes it can be made of calcified particles as well. Once these plaques are covered by a thick fibrous cap, we call them as a stable plaque. And those are the patients that we see in the office when they come in with chest pain and then they have angina, which could be a chest pain or shortness of breath on exertion. These are related to a stable non-calcified plaque. And unfortunately, when if this is not taken care on time, the cap that's actually covering the plaque can become thin and it can rupture. And then that leads to plaque rupture, and that results in acute myocardial infarction, also known as heart attack. That's exactly what Dr. Rajesh was alluding to regarding this patient. So now you can see the importance of inflammatory cells that actually starts the whole pathophysiology in this. And although calcified plaques are not so much inflammatory, pro at the beginning, but we know that towards the end, it's also smooth muscle proliferation and a lot of inflammation is involved. So that's the progression of atherosclerosis and a little bit of inflammation into it. So now how psoriasis comes into the picture. As you can see from our labs that we published in American Journal of Physiology and Open Heart Journals, we propose a three-way mechanism by which psoriasis can actually result in accelerated atherosclerosis. The first and foremost is inflammation. So there's psoriasis puts your body in fire. It kind of triggers like a ring of systemic inflammation with immune cells activation, as a result of which all your inflammatory biomarkers go elevated, which is the HSCRP, the TNF alpha, the interferon gammas, and the different interleukins. And due to this, there is actually a process that results in accelerated atherosclerosis. The second mechanism, possibly, that leads to accelerated atherosclerosis in patients with psoriasis is because of metabolic derangement. You have issues with your insulins where you have insulin resistance or impaired fasting glucose. And because of this, there's actually a upward regulation of like inflammatory markers and adipocytokines, which is well known to cause accelerated atherosclerosis. And finally, the big elephant in the room is your lipids, the lipoprotein dysfunction. We know that patients in psoriasis, they actually not only have increased amount of ApoB, which is actually a pro-inflammatory marker, and that actually increases the LDL in the system and decreases the LDL washout, and also decreases in patients with psoriasis, there's a decreased HDL concentration, both in terms of the quantitative and the qualitative. So even if we have a normal looking HDL, the efflux capacity of those HDL is not there or is impaired. Hence, even if we have quantitatively a normal HDL, it's not doing its job. So with this three mechanisms, we propose that patients with psoriasis are actually at a high risk of having accelerated atherosclerosis.
Excuse me, can you put it in slideshow? Full slide, please. Okay, thank you so much. Thank you.
Okay. And this is a case review. This is exactly going into what Dr. Rajesh was talking. This is a patient. So when I was at Penn and at the NIH, we used to have a psoriasis and a dermatology and a cardiology clinic. It's called the Psoriasis Heart Clinic. So where we see patients, even though they don't have any cardiac risk factors or they don't actually have any other prior cardiac events, but if they have any kind of psoriasis, they kind of get referred to us because we were running a large database with these patients. And also, we were trying to follow these patients up for a long period of time and aggressively prevent these patients from getting any bad outcomes. So I'm actually presenting a similar exact case what Dr. Rajesh was alluding to. It was a 44-year-old female. She came for a general evaluation, like a general checkup. The only past medical history she had was borderline hypertension. Of course, she had untreated psoriasis, and that's the reason why she came there. And she was not on any medications. She was like a normal hippie 44-year-old person. And her family history was significant for diabetes in her mom. And her father had actually significant early premature CAD. Like we defined that as less than 55 in first degree male relatives and less than 65 in first degree female relatives. Meaning like if someone actually had a MI at those age groups, then you actually define as premature CAD family history, and she did have that. She was also an ex-smoker, and she quit in her early 30s. She uses alcohol socially and no drug abuse. Her review systems were pretty much like unimpressive, I would say, except she said she may get fatigue and maybe slow down at times. And with her exam, her vital signs, you can clearly see she was hypertensive. And with her BMI, she was on the bigger side. This is a or BMI class 1 obesity. And her waist hip ratio was 1.0. And rest of her cardiac and other respiratory exam was non-significant. And I'm not a dermatologist, so with due disclosure, but she actually had a 9% body surface area involvement of a plaque psoriasis on the trunk, elbows, knees, and scalp. So in our clinic, which is a unique setup, we actually have a dermatologist and a cardiologist sitting together and evaluating the patient. And the dermatologists do their assessment of how bad the psoriasis is and what is the percentage involvement. And then the patient comes to the cardiologist to actually further risk stratify the cardiac risk and what are the preventive things that can be done. So that's kind of like a collaborative clinic that we have used to have at Penn at the NIH. And for laboratory data, which came back a week after we saw her, you can see there's significant derangement in the cholesterol levels. As we know, any high amount of LDL, which is the bad cholesterol, is very bad. And any low amount of HDL, which is the good cholesterol, is also not good. So she had a LDL of 159 and a HDL of 40. And her hemoglobin A1C and her fasting glucose were all suggestive of she's pre-diabetic. So she definitely had that metabolic picture of having obesity, of deranged lipid levels, and pre-diabetes status. So in summary, we have a 44-year-old female with untreated moderate plaque psoriasis, prior history of tobacco use, and a significant family history of coronary disease, and does not carry a diagnosis of hypertension, but has prior encounters where her blood pressure has been high, and she's obese class 1, and she's pre-diabetic with a glucose and hemoglobin A1C which is high. So if you actually put all our numbers into traditional risk factor or a risk score model that we have, this is just the Framingham risk score. So whenever we see someone in the cardiology clinic, there are different ways how you can predict how someone can actually have a major adverse cardiac event, meaning like a heart attack or a stroke or a non-fatal MI in the next 10 years. And one of the most validated one is the Framingham risk score. It comes from a cohort in Boston, that's Framingham, and they've actually followed like generations and generations of patients over there, or actually normal people. And then they've seen like what are the common things that can affect someone's survival or over a period of a long follow-up term. So if we put in all those numbers here, so it's usually the age, LDL cholesterol, HDL cholesterol, what's your blood pressure, are you diabetic or not, were you a smoker at some point, and then it adds up to a particular number, and then you actually see with the age and those composite number, what is your risk? So if we actually plot in the numbers for our patient over here, you get 9% Framingham risk score, which by the traditional risk model is actually low risk, meaning like everyone will shy away saying, yeah, don't worry, you'll be fine. Just keep doing annual physical exam, uh, try to lose some weight, you'll be fine. So, but the question now is, how are we going to assess the inflammation role that's associated with the psoriasis? What are the systems and the models that we have, both subjectively and objectively, to quantify how much psoriasis can add to her risk of having a major adverse cardiac events in the future? And so first of all, the question then boils down to, what is inflammation? Why do we care about inflammation? And does inflammation matter in cardiovascular disease at all? And the answer is absolutely yes. Because if you look at this graph where Dr. Libby and Ridker had published way back in early 2000s, where they studied that the circulating levels of inflammatory biomarkers go up in any patient who actually has cardiovascular disease, either risk factor for cardiovascular disease or had some cardiovascular disease event in the recent past, or ongoing issues. And if you look at the bottom of the table there, where the y-axis is all the inflammatory markers, and the x-axis is actually looking at your relative risk of future cardiac events, high sensitive C-reactive protein is super duper predictive, and the risk is actually about 4 times than if you actually have a normal C-reactive protein. Meaning, like if you actually have an elevated C-reactive protein in your blood levels, irrespective of the other traditional risk factors and your other personal history and all the other history that goes into, you are at 4 times increased risk of having a future adverse cardiovascular events. So it does tell that there's definitely some role of inflammation in cardiac disease, and unfortunately, it also prognosticates the disease process in cardiovascular disease. And let's go back to now psoriasis. So psoriasis is a chronic inflammatory skin disease, as we all know, and there's a lot of patients who's actually diagnosed, and unfortunately, there's a lot of patients who are still underdiagnosed or misdiagnosed just because of the lack of insight. The patients are not able to come because of the lack of resources, or unfortunately, they're not able to get to the specialist who can actually diagnose them appropriately. And that's the reason why there's a lot of patients still walking around with either undiagnosed or misdiagnosed psoriasis. And if you actually look up, there's more than 1 billion immune cells activated within our body during a severe psoriasis flare up. And this is a very, very fascinating and important slide. So this is our work where we actually studied using a British database from 1987 to 2002, where we included several thousands of patients, and we actually graded them as who have severe psoriasis and or on immunological therapy or biological therapy versus patients who did not have severe psoriasis. And it's a retrospective, kind of like a large retrospective registry analysis. And we followed these patients and we stratified the risk of outcomes with patients with severe psoriasis and with no severe psoriasis. And what you found there is patients with actually who had severe psoriasis, they had 50% increased risk of mortality. And these patients are not your elderly people. This is a young patients, 40-year-old. And even at that time, their risk compared to patients who don't have severe psoriasis of having a major adverse cardiac events is, is tremendously high. And when we did the hazards ratio, as it's shown there, the severe psoriasis puts you at a 1.58% higher risk of having an MI, 1.43 risk of stroke, higher risk, cardiovascular death 1.57, and any major adverse cardiac events 1.53. This is after adjusting for all the other traditional cardiac risk factors like diabetes, smoking, hypertension, family history, your cholesterol numbers, obesity, body weight. Even after adjusting for all this, there's an independent association of severe psoriasis, even in the younger age group, affecting mortality and cardiovascular morbidity. So now let's go back to, again, the same slides that we discussed. So is this only in stable coronary disease, or does it even cause heart attack? That goes to say that we need to understand more about if psoriasis affects only stable coronary disease, or if it actually causes an inflammatory state that puts patient at a higher risk of having unstable plaque and put them actually at the risk of having an MI. So to answer those questions, we did further studies. So the first one is you can actually see that having psoriasis and acute MI, which is a heart attack patient, you take the blood work and you do the inflammatory biomarkers. And the inflammatory biomarkers are almost comparable in the psoriasis patients to someone who's having a heart attack, which is pretty, actually, if you look at it, it's even higher level compared to the patients who are having ACS. So the TNF alpha is 18.1 in patients with psoriasis, and with acute coronary syndrome was only 2.4. And patients who never had ACS, meaning they still have a plaque, it's a soft, stable plaque. In those patients, the TNF was only 0.8. And interleukins were the same too, significantly higher compared to the patients with ACS. So, and it's a significant p-value, and this is across a few hundred patients. And this shows that, one, psoriasis is as inflammatory as having a heart attack, which is kind of like fascinating and also kind of eye-opening for all of us. And now let's try to explain how and why. Now we know that whenever someone has a cardiovascular problem, there's increased level of inflammation. And whenever someone has psoriasis, their inflammation goes up. The inflammation goes up even more than someone having a heart attack. So now how you can actually merge these together? Why does that happen? So first thing is the lipids. So when we look at the lipid panel that's done in our clinics, it's usually looking at the absolute numbers of the lipids. So what's your LDL? What's your HDL? What's your total cholesterol? What's your triglycerides? What's your VLDL or the non-HDL cholesterol? So, but those things could be grossly normal. But if you go into a little bit depth about how these particles are made of, because we know that as the particles of the cholesterols go smaller and smaller, they're becoming more and more atherogenic. So what we have shown with the group with Sorkin is that in patients who actually have psoriasis, depending on irrespective of whatever severity that they have, the number of smaller LDL particles go up, and the number of intermediate density lipid particles also go up. Those are the two biggest culprits, actually. If you see whenever there's a formation of a coronary artery disease plaque. So, and this is because of upregulation of a pro-inflammatory marker called the ApoB. So it is a direct correlation with increased levels of ApoB, which indirectly increases all the bad small LDL particles and the intermediate density lipid particles. And this is well established. So that could be one mechanism. And the second mechanism is we talked about how psoriasis is actually doing more of the bad, just the LDL. And what happens to the good cholesterol, which is the HDL? We talked about two things when we started the talk. One, the HDL can still be normal, but they are not qualitatively normal, or the HDL could be low. So how do you define the quality of HDL? It's called cholesterol efflux capacity. So whatever you're seeing in this slide tells the function of what HDL does. It takes the cholesterol from macrophages and the foam cells, and with several receptors, it actually kind of get transferred from a nascent HDL to a mature HDL, and the mature HDL pushes this cholesterol, that's called the cholesterol efflux, into the liver and gets metabolized in the bile. So if you have a good normal metabolism, this is all good things. So having more of LCAP, that's the enzyme that actually does this process, is good. Having more of ApoA1, unlike the ApoB. ApoB is bad, but ApoA1 is good. But if you actually have any issues with these processes, then even though if your HDL cholesterol is normal, but the quality is not there, then that's bad. And that's what we've shown in the efflux value here in this graph, that in psoriasis patients, the efflux value is far lower compared to the controls, which is higher, with the relative p-value of 0.021, which is published in both Atherosclerosis and European Heart Journal. So now we know from one of the mechanisms is because of the lipid dysfunction that that's happening in psoriasis, that's actually putting at a high risk for coronary artery disease. So now, should we go ahead and CT scan everyone? Do we do a CAT scan of the coronary arteries of everyone because they have psoriasis? Like, and even if we do a CAT scan, do they even have any blockages or like any kind of like events before they have suffer a clinical event? Do they even have a significant stenosis or a blockage? So we did those studies. This is what we're going to discuss next. So the gold standard method of how you actually find a blockage in the coronary artery is by a CAT scan, and that estimates not just the blockages in the arteries of the coronary arteries, but also gives you a total plaque burden. So whenever we look at a CAT scan of the coronary arteries, we look at what's the total plaque burden, and what's the non-calcified plaque burden, what's the calcified plaque burden, and out of these, any of these are actually in a specific arteries, like the LAD or the left circumflex or the RCA, and how many of these are actually causing obstructive disease. And if it's causing an obstructive disease, if it's a high risk feature, meaning like we have to take the patient for an invasive coronary angiogram and try to see if we need to fix this or not. That's when the CT scan shows the plaque is associated with high risk features. So let's see how patients with psoriasis have those. So that's exactly what we discussed. So if psoriasis and cardiovascular disease share inflammatory pathways, which we just saw, maybe the coronary arteries be affected in psoriasis patients even without symptoms. How do we know, and what do we do about it? So how do we know? Because we actually, in our lab at the NIH, we did the coronary tree extraction. How any patient who's actually getting the coronary CCTA, we had a couple of scanners which are much bigger and better than the usual commercial scanners. And what we did was we did the reconstruction of the coronary arteries, and then we split them open in both cross-sectional and the longitudinal view, like a snake, like you can see on the right side, because that will give you the whole volumetric plaque burden assessment. And how do we come up with this formula? So this is a formula that we published in European Heart Journal in 2015. So how have we come up with this is because of this little bit of a software. But what we are trying to find is you're going to find the total volume, which is easily calculatable, and then you're going to find the lumen. And whatever you subtract is going to be your plaque. So, and then for plaque index, because we got to actually figure out how many segments we're assessing, and then we have to kind of have a centralized way of actually comparing things. So then you sum all this plaque volume divided by how much length of a segment. For example, if I analyze 10 millimeter of LAD or 7 millimeter of LAD, so that will be the length of the segment, and sum of all this plaque volume will give you and the divided by the length of the segment will give you plaque index. And what we found is first thing, the first paper was the one we published in 2015 is the cholesterol efflux capacity, which is what we looked at in this slide. Even if your HDL is good, but if your efflux or the ability for the HDL to throw the cholesterol out is not good, then qualitatively the HDL is not a good cholesterol, even though you can have normal HDL. So we looked at the cholesterol efflux capacity and we compared that cholesterol efflux capacity to the coronary CCTA by angiogram, assessing the plaque volume and the plaque burden and the plaque index. So we enrolled like 101 patients from our NIH prospective cohort. And what we did is we actually compared both the cholesterol efflux capacity and the CT scan findings. So whenever we do a CT scan, there's three kinds of plaque that we talk about. Total plaque burden, which is PB, and then there's a non-calcified plaque burden, which is the NCB, and there's a calcified plaque burden, which is the CB. So you can see that cholesterol efflux capacity, as the name suggests, the higher is good because the HDL is actually actively effluxing the cholesterol from the macrophage and the foam cells into the liver to get metabolized. So if you have more efflux capacity, less like cardiac bad things can happen. So you can see that when CEC and the non-calcified plaque burden were inversely correlated. So if you have more CEC, you have less plaque burden, especially the non-calcified. And even when we adjusted for all the other cardiac risk factors and other cholesterol parameters like the HDL and the ApoA1, this negative correlation persisted. So what does it say? That if you have a you have some impairment in your cholesterol efflux capacity, that's going to cause issues for you to have a plaque in your coronary arteries. And very interesting thing that we found, if there's a significant gender interaction. So women who actually had low cholesterol efflux capacity had a higher non-calcified plaque burden compared to men. So for example, there are two patients, both had low cholesterol efflux capacity, but one was a male and the other one was a female. The female, even though they had the same low cholesterol efflux capacity, the female had more plaque burden compared to the males. And so what we came out or suggested to the community is that when you're looking at the lipid panel, you just not look at the lipid panel, look at the size of the lipid particles and look at the cholesterol efflux capacity. And the cholesterol efflux capacity can therefore be, excuse me. So the low cholesterol efflux capacity may be an important biomarker for subclinical coronary atherosclerosis in psoriasis patients. And then we actually did another study where we had three groups. One is patient psoriasis patients. The other one, 10 years older than psoriasis patients, but actually had an indication to go on a statin because they had hyperlipidemia. And the third one is the healthy volunteers. So for this slide, we're just going to talk about psoriasis patients and healthy volunteers. So if you look at the psoriasis patients and the healthy volunteers, by the CCTA analysis that I explained to you, the total plaque burden and the non-calcified plaque burden was significantly higher in patients in psoriasis compared to the healthy volunteers. No surprise, right? And then when you actually even adjust for other risk factors like age, gender, their blood pressure, their cholesterol levels, their sugar levels, their smoking, and their lipid treatment, the relationship still persisted, meaning patients with psoriasis still had a high non-coronary or non-calcified plaque burden compared to healthy volunteers. So this is exactly what we talked about, how a stable plaque, non-calcified, can still be dangerous, leading to a plaque rupture when the cap that's actually filling these stable plaques break up. So it's called thin cap fibroatheroma, and then they break up and then they get out. So the next question is, okay, so you actually proved that the plaque burden is high. Okay, so if the plaque burden is high and the patients with psoriasis actually have coronary artery disease, are they at a higher risk of having cardiac events like heart attacks? Yes, the answer is yes, because you can see this is a representation of a coronary CCTA where in patients with psoriasis, you actually have other positive remodeling that's actually seen on the CAT scan, which is suggestive of a high risk plaque. And this is in compared to patients who actually have no psoriasis. And this is the table that compares psoriasis patients, but not the healthy volunteers, but like 10 to 15 years older than the psoriasis patients, but have only high cholesterol. And what it shows is the same thing, that even if you're younger, 15 years younger, and you don't have hyperlipidemia and other risk factors, your presence of high risk plaque is as comparable to someone who's 15 years older than you and have high cholesterol. So this is a very, very important finding, and something learning, kind of like objective or learning kind of finding, I would say, that it doesn't matter if you're young, and doesn't matter if you actually don't have the traditional risk factors to have coronary artery disease, but still, if you do the CAT scans and if you have psoriasis, you are at a higher chance of finding a high risk plaque in these patients compared to their older, healthier, non-psoriatic counterparts. And this is so now how do we treat them? Like, and do these plaques, high risk plaques, actually get better if we do treatment? So that's we actually did a study to assess that. So this is a representation of the same, where you can actually see that there's a lumen gain here after this is the before and this is the after. You can see there's a stenosis here narrowing, and here this is better now. So does treatment of chronic inflammation modulate coronary disease characteristics? In other words, if you treat chronic inflammation, are you impacting any changes in your coronary arteries? And the answer is we'll find out. So we actually did a study where we enrolled consecutive patients with moderate to severe psoriasis who started biologics, and we compared those patients with the same moderate to severe psoriasis, but they were not on any biologics. And we did the same CCTA scans, and we compared to what it was at baseline, and we compared to what it was at 1 year to see if there's any change in their plaque. And very interesting, you can see that in the non-biological group, the inflammatory biomarkers were actually unchanged from what it was at baseline. But if you look at the patients who received the biologics for moderate to severe psoriasis, there's a 33% reduction in the inflammation level at 1 year compared to their non-biological counterparts. So it goes to say that there's some things that we can do to bring these amount of inflammation down in patients with psoriasis, and biologicals could be one of them. And this is a representation of the characteristics of the plaque on the CT scan. And you can actually see that A and B, the A is actually at the baseline and 1 year, B is the 1 year follow-up. And you can actually see whenever there's a red color, that's a necrotic plaque, and that's not good. And white is calcium, and green is much more stable plaque, which is the fibrofatty plaque. And you can see patient who actually received the biologics, they actually have an improvement in moving from a necrotic core to a much more stable light green core. So that's also telling us that it's not only decreases inflammation by the presence of low amount of inflammatory biomarkers after treatment at 1 year, but also it improves the characteristics of the plaque, making the high risk plaque probably into a low risk plaque. So, and if we look at this, this is the table that explains what happened to these patients when they did biologics. When they did biologics, at baseline, the total plaque was 1.3, it dropped to 1.2, so 5% decrease. And the non-calcified plaque was 7% decrease. And same moderate to severe psoriasis patients, when they did not do biologics, unfortunately, it did not result in any decrease in their plaque burden. And that was just for the calcified, non-calcified plaque, and this is the high-risk plaque. And this is the picture that we saw, that when you use the biologics, the fibrofatty burden actually goes down, and the necrotic core burden goes down. And compared to the non-biological group, there's no much improvement in those characteristics. And this is the similar representation of the same thing that we spoke on the other slide. And this is the graph that actually tells you baseline in 1 year. You actually don't treat them at all, no difference. If you treat them with biologics, you actually see a good reduction in this perivascular fat attenuation index is actually what we are looking at here. That means that your fat around the coronary arteries and the other remodeling things are going down. So less is better or less is good there. So that's significant there. And when you do anti-TNF alpha, you still have a little reduction and still is statistically significant, but not too much. And then when you do the other anti-interleukins therapy, you still see a reduction. But the amount of reduction is highest with the biological treatments. So these things are not available to us. Even if you go to another center in the US, it's not available as a part of the routine practice. The coronary CTAs are available for practice, but doing all this detailed analysis is not available in practice. So then what else can we do to make sure that this is more practically you can apply to your patient that you see in the clinic? Something called higher resolution coronary imaging. We're working on a VascuCap. It's an histopathological thing that actually goes into the bottom of like quantifying how much lipid-rich necrotic core you have. That is a bad thing to have, and that will actually directly correlate with your plaque burden and plaque analysis. So what happens with chronic low-grade inflammation? So you say, you know what, doc, I know that I have psoriasis, and you saying that psoriasis is bad, but psoriasis is not bothering me. And I just get it once in a while when the winter comes or something happens, some precipitating factor or something gets in. I apply some steroids or some creams that my dermatologist give, and I'm happy. I'm fine. Like, why do we even bother doing all these things? Then what evidence do we have to say these patients? So in our cohort of these like psoriatic cardiovascular clinic patients of over 400 people, which we have followed for almost 10 plus years now, we found that if we don't treat, even if it's a low grade of inflammation, meaning mild psoriasis, if you don't treat them, seem to have a higher prevalence of hyperlipidemia and metabolic abnormalities with their sugar levels, dysglycemia. And it is modifiable with just diet and exercise because they're still young, they're still low risk. You don't have to necessarily put them on medications unless you actually have other objective markers that they're going in the wrong direction. But still, it is definitely modifiable and treatable. You can tell the patients you can help yourselves if you do things by not taking medicines, but just do the natural way. And you can actually try to avoid a risk of having any major adverse cardiac events in the future. But we know that if it left unaddressed or untreated, like how what happened to Dr. Rajesh patient and also our patient here, I'll show you what happened to that patient. It can result in serious cardiac events or cardiac disease. And the worst part is without any symptoms. And you probably would say, I did all the screening and everything looked okay. LDL was not terrible and the sugar was okay and blood pressure was a little high, but still I had a heart attack. So let's go back to our patient now. Our 44-year-old female who was untreated moderate psoriasis. You can actually see all those. This is the coronary arteries that you can actually see. When we do the coronary arteries, we get it to the EKG. We do systolic and diastolic to calculate the percentage stenosis. And we also give nitroglycerin to see if there's any spasm, or if it's a real stenosis, then it gets even augmented when we give the nitroglycerin. But all this white plaques that you see is actually suggestive of calcium. So you can actually see all those lit up, and you can see how critically she had a proximal LED. As you all know, proximal LED is called the widowmaker. So she actually had a more than 70% critical lesion in a very, very important artery called the proximal LED in someone who was kind of like stratified as low risk in the Framingham risk score category. And she also actually had, and this is another view of the same artery that you can see here, that she had 70%. But the good thing about these blockages, it's all like non-calcified. So if you're into the more details of how to fix these blockages, non-calcified blockages are your friends because it's easily you can actually plaque modify it, and you can actually do a good job with the stents, especially if the patient is symptomatic despite being on medical therapy, compared to other kind of like calcified plaques, which is hard to, which is still treatable, but you need to do a little bit more work. So what do we say to ourselves? Like, what did we learn from this? What did I learn from this? What did we all learn from this? We got to screen patients and we got to educate our providers. Who to screen? Any patient with psoriasis should get at least one screening once in a year for cardiovascular risk factors. Not only just one time and done. uh, do it at the time when they were diagnosed, or even if they're diagnosed multiple years back. But if you're seeing them in the office, do it at the time of that time, and then keep doing that at least the age appropriate American College of Cardiology guidelines, or whatever guidelines that the Indian institutions also propose, which is probably once a year screening of everything. And the screening doesn't have to be done by interventional cardiologist or cardiologist. It can be done by any healthcare provider, residents, house staff, fellows, dermatologists, internists, primary care. Anyone can do all this screening. It's just the usual screening that we do. And what to screen and how to screen. So usually it's a metabolic picture. So blood pressure, BMI is very, very important, which we tend to sometimes overlook. And the obesity is BMI is more than 30. For the Asians, there's a controversy that lower BMI, maybe 27 and above, is even considered obesity. And then the blood for glucose and lipid panel. Those are the most important things. Um, there's a big thing about fasting versus non-fasting. So, according to the most recent AACC AHA guidelines, you don't have to fast. However, if you don't fast and do your blood work, and if you actually have very abnormal like lipid numbers, then you actually make the patient fast and repeat them again to see if this was directly related to whatever they had, or this is just a pattern that they have in their blood. And there's so many of us actually learning about it, and as a community. And finally, the American College of Cardiology and the American Heart Association came up with their guidelines, where psoriasis is included in one of their risk enhancing factor for early initiation of statins. So even the guidelines are coming up. So what is the therapeutic plan for our patient going back? Keeping our blood pressure under control by diet and lifestyle. If doesn't work, then you do first line antihypertensive, lose some weight that helps with the blood pressure also. Hyperlipidemia. There's no goal LDL, because we have learned from all the statin trials. The lower most you go, the better you are, especially if you're at a higher risk of any major adverse events. And especially in patients with psoriasis, which is a pro-inflammatory state and at a risk of having an increased cardiac events, I would say whatever statin dose the patient can tolerate, aggressive or intensive statin therapy would be my choice. And metabolic syndrome, obesity, work with your dietitian or do things to lose your weight. And for psoriasis, I leave it to the experts there. Treat, educate, and repeat. So in conclusion, systemic inflammatory disease, it includes a panel of everything like rheumatoid, lupus, and psoriasis, and every single systemic inflammatory disease have consistently shown through both prospective and retrospective studies that it accelerates cardiovascular disease. Absolutely no doubt about it. And systemic inflammation in psoriasis is associated not just with coronary artery disease, but the spectrum of cardiovascular diseases that spans from metabolic syndrome, abnormal lipid metabolism, abnormal glucose metabolism, and coronary artery disease both in the setting of stable and unstable, and even a heart attack. So education and awareness are much needed to improve cardiovascular disease-related mortality. And with that, I conclude. And the take-home message is psoriasis is not just skin, it's more than skin deep. And with that, I'd like to conclude. Thank you for your time and attention, and I'm happy to answer any questions. And if there's any questions that you may actually have that comes up later, please feel free to reach me as well. Thank you. I can't hear you, actually. Can you hear me? Oh, I can hear you now. Yeah, I can hear you now. Sorry, go ahead.
Thank you, Dr. Parasuram, for such an engaging session. And it's good to know that there are such integrated clinics for cardiovascular care of psoriatic patients also. And we do see some occasional young psoriatic patients without any conventional cardiovascular risk factors landing in the cath lab. And what is there any specific markers to look for these psoriatic patients other than the conventional markers in the routine practice?
Sure. Thank you for the question. So I think that's a very practical question. So if I see a patient who comes to the clinic and we want to risk stratify these patients for whatever reason, because the patient is motivated and wants to know what the risk of having a major adverse events in the future is, I usually do the usual panel, which is the regular lipid panel, not the lipid size, and not the nuclear magnetic resonance. Just a regular lipid panel, hemoglobin A1C, and a CRP. If the CRP is high, then that triggers the next channel of events. So then the next channel of events would be the LP little a. So we know that when your LP little a, which is also another pro-inflammatory marker, is high, and when your CRP is high, now you got to ask ourselves, why are these things high? Especially if we don't have a reason. If we have a reason like psoriasis, then I refer to my dermatology colleagues and tell them, you know what, you got to aggressively bring these things down. And on top of that, we tell the patients to do diet and lifestyle modification. But to answer your question, you usually do the hemoglobin A1C, lipid panel, and then CRP. If all of them are normal, then I think you're still okay. But if the CRP is high, then you go to the next level by doing the LP little a, and then figure out why these things are actually abnormal.
Thank you so much, Dr. Parasuram, for enlightening us about how to screen the patient with psoriasis and how to manage them. And then you know that the biologics are nowadays stay on therapy for psoriasis so that we can be able to control the inflammation. And then definitely the management of psoriasis is a team effort. And because unless we look at the comorbidities with increasing tobacco consumption and alcohol substance use disorders and all. So it's a teamwork of physician, cardiologist, psychiatrist, then the dermatologist. So as you have rightly put, psoriasis is a systemic disease, not just skin disease. Thank you so much. Thank you for enlightening us regarding the cardiac research in psoriasis. Thank you.
Thank you, Dr. Rajesh. Thank you, everyone, for your time.